All right, let's jump right into this explainer and demystify the complex ICD-10-CM coding rules for abnormal products of conception. If you've ever found yourself staring at a patient's chart, scratching your head, trying to figure out exactly which characters to use for an ectopic or molar pregnancy, well, you're definitely in the right place. Today, we're going to break down these guidelines step by step so you can code these encounters with absolute confidence and precision. Here is our agenda for today. We'll start with the 000 to 002 landscape, look at molar and biochemical pregnancies, dive into the specific ectopic pregnancy rules, cover coding patient history, discuss the Z3A exclusion rule, and finally, how to stay updated.
Section 1. The 002 to 002 coding landscape.
To kick things off, we need to know the core categories we're actually working with here. Ectopic pregnancies, those are classified under category 000. Now, if you're dealing with a hydatidiform mole, you'll want to look to category 01. And for other abnormal products of conception, you'll use 002. These are your foundational codes, but, and this is an incredibly important reminder straight from the guidelines, if any complication occurs during these conditions, you absolutely must use an additional code from category 008. It's basically a two-part harmony when complications pop up.
Section 2. Molar and biochemical pregnancies.
Now, in this category, strict clinical definitions completely dictate your exact code. Let's look at the blighted ovum. This typically happens in the first trimester. A fertilized egg successfully attaches to the uterine wall, and the cells develop to form a pregnancy sac, but the embryo itself just doesn't develop. This is often caused by a really high level of chromosome abnormalities. Because it develops into a benign tumor or mole, it's classified as a non-hydatiform molar pregnancy, so you'd code this under 02.0. Keep in mind this is completely separate from a hydatiform mole, which gets its own specific category of 001. On the flip side, we have the biochemical pregnancy. This is literally the earliest form of miscarriage. It happens when the fertilized egg doesn't implant properly in the uterus. It's called biochemical because, well, the pregnancy is simply too early to confirm through a standard ultrasound. It can only be confirmed through biochemical testing. Because of this very distinct clinical picture, a biochemical pregnancy is included under a totally different code, 002.81. To really wrap our heads around 002.81, we've got to talk about human chorionic gonadotropin, or HCG. In a normal early pregnancy, this hormone level should double approximately every 2 to 3 days. But in abnormal cases, you'll see a decrease in that doubling time, and an ultrasound won't show a gestational sac at all. And honestly, this brilliantly illustrates why we use code 002.81. When an ultrasound cannot demonstrate an intrauterine pregnancy and there's an inappropriate change in the HCG doubling time, a doctor has to rule out an ectopic pregnancy first. Once ectopic is ruled out, the miscarriage is officially confirmed. That is exactly when you assign 002.81 for an inappropriate change in quantitative HCG in early pregnancy.
Section 3. Ectopic pregnancy character rules.
Let's move to the most complex part of our explainer. An ectopic pregnancy happens when a fertilized ovum implants and develops anywhere outside the uterus. Now here's a fascinating clinical shift. With the massive rise of assisted reproductive technologies, you'll actually often see an increase in multiple gestational pregnancies, where a normal intrauterine pregnancy coexists right alongside an ectopic one. Our coding system has to be robust enough to capture that exact complexity.
So the crucial thing to remember is that assigning an ectopic code from category 000 is kind of like building a mathematical formula. Step 1, your fourth character defines the specific extrauterine location. Is it tubal, ovarian, abdominal? Step 2, your fifth character tells us whether it is with or without a coexisting intrauterine pregnancy. And finally, step 3, your sixth character defines the laterality. Is it on the right, the left, or is it unspecified?
This maps out exactly how that sixth character changes for tubal and ovarian pregnancies based on laterality. Let's trace one out together. Take a right tubal pregnancy without an intrauterine pregnancy. The location is tubal, so that's 000.1. Without an intrauterine pregnancy makes the fifth character a 0. The right side makes the sixth character a 1. Put it all together, you get 000.101. If it was on the left, it shifts to 000.102. Now, if there is a coexisting intrauterine pregnancy, that middle number changes to a 1, giving us codes like 000.111 for the right side or 000.112 for the left. And the logic is perfectly identical for ovarian pregnancies right down there in the O00.2 category.
But wait, what if the pregnancy isn't in a tube or an ovary? Well, notice that for abdominal, other, or completely unspecified ectopic pregnancies, you actually just stop at the fifth character. Why? Because laterality simply doesn't apply here. You can't really have a left or right abdominal pregnancy in the same way you have left or right fallopian tubes. So for an abdominal pregnancy without an intrauterine pregnancy, you're looking at just O00.00.
Section 4. Coding patient history. Accurately capturing a patient's history is absolutely vital because past conditions significantly increase the risk for future pregnancies. Patients who have had an ectopic or molar pregnancy are at a much higher risk of having the exact same complication in a subsequent pregnancy. So, if a patient has a history of an ectopic pregnancy, you must assign a code from O09.1- for their supervision. But if it's a previous molar pregnancy, that requires a code from subcategory O09A. These codes act as critical, giant red flags during the prenatal period, alerting the entire healthcare team that this is a high-risk pregnant woman needing specialized monitoring.
Section 5. The Z3A exclusion rule.
Before we wrap up, I have a quick scenario to test your knowledge. When you're reviewing documentation for an ectopic or molar pregnancy and the chart clearly states the patient is at exactly 8 weeks gestation, should you also build a Z3A code to report those specific weeks of gestation alongside your O00 to O08 codes? What do you think?
The answer is a hard no. I know, it's incredibly tempting to add that extra detail because it's sitting right there in the chart, but the rules strictly prohibit using Z3A codes for abortive outcomes. In fact, this exclusion also heavily applies to the elective termination of pregnancy, which is code Z33.2, and to postpartum conditions. Category Z3A is simply not applicable to these scenarios. Full stop.
Section 6. Stay updated and subscribe.
The ICD-10 official guidelines leave literally zero room for interpretation here regarding the Z3A exclusion. This really showcases exactly why precision and constant education are the absolute hallmarks of a great medical coder. The rules are highly specific, and getting just one character wrong changes the entire clinical picture you're reporting.
And that brings us to the end of our deep dive into ectopic and molar pregnancy coding. If you really like these medical coding videos and want to remain updated on all the latest coding rules and guidelines, please be sure to like this explainer and subscribe to my YouTube channel right now. Turn on those notifications so you never miss a coding update. But before you go, I want you to think about this. If coding guidelines demand this level of precision for extrauterine locations today, how will our medical coding systems need to evolve to keep up with the rapid, unprecedented advancements in artificial reproductive technology tomorrow? It's a lot to ponder. Thanks for hanging out with me, and I'll catch you in the next explainer.